Hello, I'm Rob Ettaro, and I'll be talking about some of our work in developing a preclinical model for treatment-resistant depression at altitude. What led us to investigate this are the demographic studies looking at the rates of suicide and major depressive disorder, which I will refer to as MDD. These rates were shown to increase with the altitude of residence, and you can see the relationship with the elevation map of the United States. Living at altitude induces a chronic state of hypobaric hypoxia, in that the atmospheric pressure at increased elevation is reduced. Chronic hypoxic disorders like cardiovascular disease, COPD, and asthma also increase the risk for MDD and suicide. And MDD is linked to brain serotonergic and brain bioenergetic deficits. In women, serotonin synthesis rates are 52% lower than in men. And it's important to note that women have a higher incidence of MDD, and this makes it essential to have a sex-based study. We hypothesized that housing rats at altitude would lead to a decrease in brain serotonin and brain bioenergetic markers. This would be accompanied by an increase in depression-like behavior seen in the forced swim test and anxiety-like behavior in the elevated plus maze and open field tests. You can see our chambers down here below. We saw that at altitude, females display sustained depression-like behavior as well as anxiety-like behavior, while males only display a transient depression-like behavior. We then took tissue and assayed for brain energetic marker creatine as well as serotonin. Creatine levels are decreased in both sexes, and brain serotonin is consistently reduced in females while trending towards an increase in males. The vast majority of prescribed therapeutics for depression are SSRIs, so we looked at the efficacy of fluoxetine in our model. Fluoxetine loses efficacy in both sexes, and not shown here, but paroxetine and escitalopram also lose efficacy. Since these non-serotonergic acting therapies lose efficacy, we tested the non-serotonergic antidepressants, tianeptine and ketamine. These compounds proved effective in reducing depression-like behavior in both sexes, and ketamine also improved anhedonia in the sucrose preference test. As SSRIs lost their efficacy, potentially from a decrease in serotonin, we looked for another way to increase serotonin levels. The rate-limiting step of serotonin synthesis is oxygen-dependent, and at altitude there is a reduced availability of oxygen. We look to circumvent this step by using 5-hydroxytryptophan supplementation. We did not see any reduction in depression-like behavior, but we did see a detrimental impact on their weight gain. We then looked to improve brain energetics by utilizing creatine and cyclocreatine supplementation. Cyclocreatine is a creatine analog that crosses the blood-brain barrier without the need of a transporter. These energetic compounds improve serotonin in females, but reduce serotonin in males. Both creatine and cyclocreatine improve depression-like behavior and anhedonia in females, but we only see an improvement in depression-like behavior in males. So our model focuses on a chronic state of hypoxia, leading to a decrease in brain energetics and serotonin, which may cause SSRIs to lose their efficacy and in turn increasing treatment-resistant depression and suicidal risk. Therefore, non-serotonergic antidepressants and improving brain energetics may be a new approach for MDD at altitude. Thank you.